Hello, good morning, everyone. All right, so before we start our session for today, may nagpapa-shoutout lang. So happy birthday to Patricia Aquino. Yan, so nagpa-shoutout yung friends nyo. Batiin nyo naman si Patricia. Happy birthday. Patricia, would you like something? Si Pat pala, Pat. Alright. Mukhang naiya si Pat. Okay, so reminder, participants, that please check your email para makita nyo yung schedule ng SGD. Okay. Participants, kindly check your email para makita nyo yung schedule nyo sa SGD. And SGD will actually start tomorrow. Okay, so please check your email. Alright, so kung hindi na magsasalita si Pat, okay, so let me first introduce to you ang ating speaker for today. Alright, sige, so our resource person for today is Ma'am Donabel I. Navarrete. She is a registered nutritionist dietitian and the manager of the Clinical Nutrition Services section at St. Luke's Medical Center, Quezon City. She previously worked as a nutrition consultant at Westmont Unilab. She graduated with a Bachelor of Science degree in Nutrition from UP Las Baños, where she was awarded with a Distinguished Alumni Award last October 2019. She also finished her MS Hospital Management in Trinity University of Asia. Ma'am Navarrete specializes on clinical nutrition and subspecializes on critical care nutrition, enteral and parenteral nutrition, and feeding difficulties for children. She is a board member of the Philippine Society for Parenteral and Enteral Nutrition, or PhilSPEN, and a member of international organizations such as SPEN, ASPEN, and the Parenteral and Enteral Nutrition Society of Asia. So everyone, to discuss clinical and hospital dietetics administration, let us all welcome Ma'am Donabel I. Navarrete. Good morning po, Ma'am.
Good morning.
Good morning, Ma'am. Thank you so much po for your patience. Okay, so I know miscommunication po with regards to your presentation. So
thank you. Okay. We can we can adjust.
All right, Ma'am. Whenever you're ready po, you can share your screen po.
May pumapasok pa ba?
Parang meron pa, Ma'am. Oh. Patuloy pa rin silang mag-e-edit.
Happy morning to everybody, mga future clinical dietitians natin. Or should I say registered nutritionist dietitians. Yan. Can you hear me clearly? Or medyo
yes,
malabo?
Clear po.
Ayan, clear naman. Okay. Allow me to share my presentation. And can you say it now?
Yes, ma'am.
Okay. Okay, our objective for this morning is, of course, to define the scope, the role, and the function of a clinical nutritionist dietitian, discuss different methods of nutrition screening and assessment, and facilitate step-by-step process of screening and assessment. So, why do we need to emphasize on this? Based on our DOHAO 2018-0033, there is a delineation of responsibilities between a dietitian, a registered nutritionist dietitian, nurses, doctors, and pharmacists. So we need to identify those especially the definition, the correct definition of nutrition screening and assessment. So, sino ba si nutritionist? Nutritionist, when you say a nutritionist, according to the Academy of Nutrition and Dietetics, this is a person who studies nutrition and provides education or counseling in nutrition principles. So, pwedeng meron o wala siyang academic degree in the study of nutrition, or pwedeng hindi, or nag-work siya in the field of nutrition. So, ito ang tatandaan lang natin, no? All registered dietitians are nutritionists, but not all nutritionists are registered dietitians. Now, in the Republic Act 10862, on the Nutrition and Dietetics Law of 2016, when we say nutritionist dietitian, so this is naman refers to a registered. So yun naman yung tatandaan natin, madali siyang madali siyang tandaan. Pag sinabing registered and licensed person who holds a valid certificate of registration and a valid professional identification card, yan, nutritionist dietitian. She's a registered nutritionist dietitian under the Article 2, General Provision Section 4. So, saan ka ba pwedeng mag-work? Pag sinabing dietitian ka, so pwede ka sa hospital, pwede ka sa nursing care facilities, public health clinics, home health agencies, corporate cafeterias, food manufacturers, or private practice. So, may mga, tayo, no? May mga friends tayo dyan sa mga different settings na yan. And when we say clinical nutritionist dietitians, ito yung mga nasa hospital, nasa healthcare facility. It could be a primary healthcare center or a tertiary healthcare worker na katulad ko. Registered dietitians assess the nutritional needs of both sick and healthy people. Then we develop individualized nutrition care plan. Of course, we want to improve or maintain yung kanilang health status. Okay, so when you work as a clinical dietitian, so you need to have a synergy, okay, together with your team members. Okay, of course, competency, kaya tayo may board exam eh. We need to pass this board in order for us to be competent enough. Okay, and of course, humility, good engagement, and just culture. Pag sinabing just culture, hindi ito yung nagsisisihan, okay, na culture, no? So patients come in different forms. When you do your hospital observation or practicum, you will see patients who have loss of appetite. Yun yung mga madalas nating makita or ma-refer sa atin. Those patients with nausea and vomiting, taste changes, there's fatigue or difficulty eating or swallowing, abdominal discomfort or pain, that eventually nakikita natin yung physical feature nila with weight loss. Yung iba may pressure ulcers, yung kapag tinurn mo sa likod merong uka, no? May malaking sugat na may uka. Sarcopenia or unintentional loss of lean body mass. Subcutaneous fat loss, kahit hindi naman nag-exercise, no, biglang or papapayat yan, no, biglang bumabagsak ang timbang. Electrolytes and metabolic derangement or imbalances, makikita natin yan. And this all, when there is deficits, eventually there is existing malnutrition. So there are signs of malnutrition. Kaya lang, clinical dietitians mostly focused on the food, okay, on the diet history. Is there a trouble in swallowing, loss of appetite? Pero hindi natin nakikita na meron pala, ang depression pala sign of malnutrition. Getting sick often is also signs of malnutrition. Okay, slow healing wounds is also sign of malnutrition. So if the patient has this, or you observe that these patients have signs, no, you have to do something. You need to intervene. Now, in JPEN 2018 or Journal of Parenteral and Enteral Nutrition, there is consensus of different nutrition experts globally, and they come up with the new definition of malnutrition. So, di ba, we do nutrition risk screening, no? We use a validated screening tool when we do our screening. Next would be, tatandaan nyo to kasi ang daming algorithm sa board exam. Next would be diagnostic or yung assessment criteria. The assessment criteria is categorized into two: the phenotypic and the etiologic criteria. So sabi dito, paano mo ba madadiagnose na malnourished yung pasyente? Ang sabi, requirement lang is at least one phenotypic criteria and one etiologic criteria para masabi mo na or ma-diagnose mo na may malnutrition yung pasyente mo. And of course, you do the severity of grading. So ito na yon, no? When you diagnose, again, one phenotypic plus one etiologic criteria equals malnutrition. When you say phenotypic criteria, ito yung may weight loss, mga significant weight loss na tinatawag, pwedeng 5% within past 6 months or 10% beyond 6 months. There is an observed low body mass index, reduced muscle mass. Okay, you can validate this by using a body composition measures. You can use a hand dynamometer. Yan. And for etiologic naman, there's a reduction in food intake or there is an inflammation. No, later I will teach you how we measure inflammation. But still, when we diagnose, the new definition of malnutrition based on the GLIM criteria, the basic parameters involved are anthropometrics, nutritional intake, and severity of illness. Hindi na katulad nung araw, na makita mo, payat na payat. Ano to, marasmic. Yung ganun kaagad, no? Ngayon, maraming criteria when you do your diagnosis of malnutrition. So what are the causes of weight loss? Kung meron kayong mga mnemonics, no? Ito tatandaan nyo rin yung ating meals on wheels. Pag sinabing causes of weight loss, pwedeng M for medications, E for emotional problems or depression, ito yung nabanggit ko kanina. A for anorexia or abuse of elders, makikita yan dun sa mga geriatric population natin. Late life paranoia, swallowing disorder, O for oral factors, N, causes of weight loss pala pag wala kang pera, no? Siguro maraming may weight loss dito. No? Kidding aside, no, poverty is one of the causes of malnutrition. W for wandering, H for hyperthyroidism, hyperparathyroidism, and hypoadrenalism. E for enteric problems or malabsorption. This is very common in the hospital setting. E is for eating problems or inability to self-feed. L, yan, no, pag naka-restricted diet sila or low salt, low cholesterol diet. And S for stones or social service. So mnemonics natin for causes of weight loss, meals on wheels. Okay, disease equals inflammation contributes to malnutrition. So meron naman kayong separate session for medical nutrition therapy. But just to show you that inflammation causes catabolism. Okay? Inflammation in a sense na it could affect to muscle wasting, biglang babagsak yung blood sugar, biglang tataas or magiging erratic ang blood sugar kahit hindi naman to diabetic. There's a higher risk for infection, poor quality of life, and impaired functionality. So kapag merong inflammation, there is a severe catabolism or increased pro-inflammatory cytokines that cause glucose breakdown. Nangyayari sa pasyente, this would cause longer length of hospital stay. So mas malaki yung babayaran. There's an economic impact. No? Kapag hindi ito na-resolve, there's more readmissions, more treatments na mangyayari. Okay? So moving on, Anorexia naman is more than just not wanting to eat. No, lagi nating napapag-aralan yan na the patient has poor appetite, blah, blah, blah. But, nung araw, hindi namin alam to, that there is such thing as neuroinflammation. Or ibig sabihin, yung pro-inflammatory cytokines nitong taong ito interact pala with the brain transmitters or neurotransmitters causing changes in appetite. Okay? Kapag normal conditions, yung anorexigenic signals mo, yung kakayahan mong magkaroon ng gana sa pagkain or kawalang gana sa pagkain is on normal signals. Pero kapag may sakit ka na, halimbawa meron kang cancer, tumataas yung signals mo, ng brain signals mo na huwag kang kumain. Kaya kawalang ganang kumain. Hindi dahil nag-i-inaute yung pasyente. Okay? This is because, yun nga, of neuroinflammation or increased anorexigenic signals. Okay, na tinatawag na hindi yan nakita noong araw. Another is sarcopenia, the key component in malnutrition. When we say sarcopenia, this is a syndrome characterized by progressive and generalized loss of skeletal muscle mass and strength. Kumbaga, hindi na natin ibe-base, halimbawa, clinical eye ang gagamitin mo na, oh, mataba to, okay pa to, no? Hindi na natin, wag na natin bigyan ng intervention kasi mataba naman siya. But when we do a CT scan, halimbawa, katulad niyang nakikita ninyo, the difference between a normal muscle mass and a CT scan of an obese patient, makikita niyo there is yung sarcopenic obesity, no? Walang laman, mataba siya pero wala siyang lean body mass, no? Kakapiranggot. And loss of lean body mass is a risk for adverse clinical outcomes. Okay? According to Dr. Demling, there is a consequences of lean body mass loss. Pag sinabi mong consequences, what will happen? Halimbawa, the patient referred to you, meron ng 20% loss of lean body mass. Okay? Ano lang to ha, pinag-uusapan natin dito, loss of lean body mass. Wala pa tong diagnosis. Ha? Kumbaga hindi mo pa alam yung sakit nito. The complications for kung meron ng 20% ng lean body mass loss is decreased healing, weakness, and infection. Yun yung related complications. And the associated mortality, ilang percent na pwede ba siyang mamatay? 30% agad. So just imagine, if the patient were referred to us, 40% na, tapos nag-pneumonia na, the associated mortality is already 100%. So the reason, when they do the new definition of malnutrition or diagnosing malnutrition, sinama nila to. No, you have to identify on how to measure the loss of lean body mass. Okay, so there is a stages of sarcopenia. So this is just a good to know slide. Okay, so para makita natin how do we measure muscle mass. So meron tayong bioimpedance analyzer, DEXA scanning, MRI scanning, even CT scan. We can use that to check, no, kung merong loss of lean body mass. Okay, and for muscle strength, we can use yung hand dynamometer, no? Hand grip, merong instructions for hand grip. And for performance naman, there is a gait speed or get up and go test. Another important factor in diagnosing malnutrition is age and frailty. This is contributory to malnutrition. No, age-related, there is a reduced strength and physiologic malfunctioning. In our center, every geriatric patients should be assessed by a geriatrician using this comprehensive geriatric assessment tool. Okay? Then kasama yan, no, maraming parameters involved. Even yung fall risk assessment, yung yung risk niya na mahulog siya. Okay? So napansin namin yan, if the patient comes na naka-wheelchair born or bedridden. So ang ano namin diyan, okay, meron ng delayed adverse outcomes na posibleng mangyari. So we need to do immediate or aggressive nutrition intervention. Okay, of course, we focused on our critically ill patients with or without referrals. Once the patient is admitted in the hospital, kailangan, yun yung one of the provision in the new AO, we need the dietitians or the registered nutritionist dietitian, kailangan makita niya all nutritionally at risk, including critically ill patients. They have to be fed adequately. Okay? But then, problem natin, especially for those in primary healthcare setting or doon sa mga malalayong probinsya. So some of the doctors failed to recognize malnutrition. Okay? They do not see the importance of kumbaga intervention when it comes to malnutrition management. There's a lack of nutritional screening. It could be because of lack of manpower din. Isa lang yung dietitian sa isang ospital. It could be lack of nutritional training, lalo na ngayon, ang hirap dahil nasa COVID pandemic. Okay? Confusion regarding nutritional responsibility, even failure to record height and weight, lalo na sa mga bata, di ba? Kung iba sa inyo kung naka-attend ng operation timbang, di ba? Hindi lang naman weight ang kukunin mo or height, no? Meron pa tayong mga Z-scores na kailangan kunin. No? And the importance of nutrition pa, yun nga, is unrecognized. So ang key thing is, again, nutrition therapy. So the goals of nutrition management, ito. So again, doon sa board exam nyo, maraming ibibigay na definition. Maraming ibibigay na word nutrition. Okay? Just remember, kunin nyo lang yung key word. Okay? Para hindi kayo nagme-memorize ng madami. When you say nutrition provision, to prevent or minimize the complication of malnutrition among patients. Nutrition support is to render metabolic milieu favorable to therapeutic modalities. Nutrition therapy is to exert a therapeutic effect using specific nutrients. Nung time namin, lumabas ang definition ng nutrition therapy. Ito, maraming tanong tungkol dito. Yung structured nutrition care process. There would be questions like, who are at risk for malnutrition? Okay, di ba? Tinatanong yan. What type, questions to ask versus yung steps involved. So, ang lalabas sa board exam, halimbawa, magbibigay sila ng case scenario, tapos magbibigay sila ng question na, what is the step, halimbawa, if I want, if I want to know the type of diet based for my patient. Okay? So, anong steps involved doon? Or how often should feeding be delivered? Ano yung steps involved doon? Okay? So, yun lang yung tatandaan ninyo. Okay? Para hindi, yun nga, you need to know the structured care, nutrition care process. And yung bawat steps. Kasi nga, lagi siyang part ng question. Paulit-ulit siyang lalabas. Okay? So, ito na. When you say nutrition screening, pag sinabing by definition, ang titingnan nyo lang na word dyan, simple, quick. Period. Okay? So, again, nutrition screening, a first contact with patient, this is a simple, quick, and general procedure used by nursing to answer the question, is he at risk for malnutrition? Okay? So, there are so many screening tools na pwedeng gamitin, okay, ng isang medical team. But in our center, we use the Nutrition Risk Screening 2002, wherein weight loss, BMI, and food intake is included in the parameter. and there is a severity when it comes to diagnosis of malnutrition. So this is a sample of the NRS 2002, wherein the nurse will get the height and the weight. Again, doon sa AO natin, ang responsibility ng nurse is to get or obtain yung height and weight, kasi i-encode niya sa electronic healthcare system ng hospital. So yun, kailangan alam niyo yung responsibility ni nurse. Okay? Siya ang mag-fill up niyang form na yan. Or kung may electronic ano na sila, healthcare program, ipapasok niya lang yung mga data na yan. Okay? Next would be, this tool naman for, this screening tool is for community and general population, or malnutrition universal screening tool, or mass screening tool, validated screening tool in UK. No? The main elements is body mass index, weight loss, and acute disease or nutrient intake. So meron siyang mga steps when we do the nutrition screening. So step 1 is to identify the patient's BMI. Then step 2 is to recognize if there is a significant weight loss for the past 3 to 6 months. Then step 3 would be, ano ba yung diagnosis ng pasyente and ano ba yung possible na nutrition status niya for more than 5 days. Then step 4 would be the overall risk of malnutrition. If the patient got a score of 2 or more, that means the patient is high risk. Ganyan. So the management for low risk, you can just provide typical full diet, or you follow the Pinggang Pinoy guidelines intended for specific population. For medium risk, monitoring is important, and if there's no improvement, or halimbawa there is a worsening of symptoms happened, then option 1 could be provision of oral nutrition supplementation, or option 2, referral na to, no, for comprehensive nutritional assessment. Kasi this is just a screening eh. Now for a high risk, yan, obligado to, refer to nutrition expert. There is a need to alter or liberalize ba yung diet? Is there a need ba to food fortificate? Yan, so ano na to, no? Ito na yung next step niya for assessment. So the dietitian will now set a caloric goal, a protein goal, and conduct a comprehensive nutrition assessment. So when we do a nutrition assessment, there is a nutrition care algorithm. Ito yung attachment dun sa AO ng DOH. So baka lumabas ito, at least alam ninyo na upon admission of the patient, there is a need to screen. Yung nakita ninyo kanina, you need to screen using a validated tool, and halimbawa, the patient is halimbawa within normal BMI, wala rin naman siyang or very low risk. You need to have a periodic rescreening. No, depende sa hospital nyo. Kami 7 days. We do a periodic rescreening after 7 days. Nurse ang gumagawa nito. But if the patient is at risk upon admission, then there is a need for patient assessment and develop a nutrition care plan and implement a nutrition care plan and so on. So ganyan siya ginagawa. No, baka kasi ibigay itong question na to, mag-ano lang, no, mag-leave ng blank. Kasi ano namin to eh. Ito yung pinaka-guide na binigay sa lahat ng hospitals ng DOH. Okay? And when we conduct nutrition therapy, there is another algorithm. We need to check if the gut is functioning or not. No, if oral nutrition is possible. So if oral nutrition is possible, pwedeng kumain sa bibig, then we provide a normal feeding plus oral nutrition supplement if we want to target more than 75% of TCR. But then, if oral nutrition is not possible, check the gastrointestinal capacity of the patient. If the gut is not functioning, then we suggest a total parenteral nutrition. If the gut is partly or slightly functioning or functioning a little, we do a combination of enteral nutrition plus supplementary parenteral nutrition. And kung the gut naman is functioning well, then we just provide an enteral nutrition. By definition, nutrition assessment is a systematic process. Ano ang kaibahan niya kay nutrition screening? Si nutrition screening is a simple and quick. Yun yung tatandaan natin, di ba? Si nutrition assessment, iba. A systematic process. Yan naman yung keyword ninyo. Of obtaining, verifying, and interpreting data in order to make decisions. Again, this is just a review. I'm just giving you tips on how to make your review easier. Okay? In reality, when we do a nutrition assessment, tama yung ABCD of nutrition assessment. Pero minsan sa kapal ng chart, ang hirap, ang hirap na mag-assess lalo na kung labas-masok yung pasyente. Okay? And there is a nutrition assessment tool that is intended for a geriatric population. So this is used in Europe, in the United States. This is owned by Nestle Nutrition Institute. And in our center, this is part of our comprehensive geriatric assessment form, wherein the dietitian is the one who accomplished the mini nutrition assessment. Okay? So ito siya. On the other hand, for adult and pediatric population, the DOH suggested a particular form, okay? But they allow us to use our own forms since we are dealing with international patients. Then we need to follow an internationally validated forms, by Mayo Clinic and by Aspen and Espen. So ito siya, So later I will teach you how we accomplish this kind of form. So again, hindi to mawawala. Laging merong tanong about the categories of nutrition assessment, And this is just to show you yung common estimate na ginagawa sa hospitals para kunin yung height ng pasyente. If the patient is wheelbound or bedridden, we use the arm span or we have knee height calipers. Pero meron din kaming electronic wheelchair scale, and ito dati namin itong ginagamit. Wala na yan. Hindi na namin siya ginagamit. Ito na may electronic bed scale na kami. Okay? It is a must that we need to get the anthropometrics of our patient kasi doon tayo magbe-based. But then there are some patients na malalaki talaga yung frame, Akala mo siya, within obese category. Pero kapag mineasure mo, okay, large lang talaga, large frame lang yung tao. So kasama yun dun sa mga tinitingnan din natin. Okay? Percent ideal body weight. Lang to, Again, this is just a review. Patient's current weight over ideal body weight times 100. I remember in our board exam, that was a long time ago. Merong tanong na magbibigay sila ng case, again, may case, tapos magbibigay sila ng height and weight, tapos kukomputin mo ikaw magko-compute ng BMI, tatanong nila kung ano yung percentage ideal body weight. So, etong mga formula na to importante, even yung weight change, Kapag lumabas daw ba, what if your computation is 84%. Anong ibig sabihin nun? Mild, moderate, severe. Yun lang yung lalabas dun sa multiple choice. No, halimbawa, na-compute mo na siya as 90% usual body weight. Anong category siya? A, B, or C. Ganyan na, no? Mild, moderate, or severe. Yun lang yung nakakalito doon. Kasi iba yung ideal, iba yung usual, iba yung percentage weight change, ganyan. Now, ang technique naman, double check nyo lagi, ha, ladies and gentlemen. Pag pinakompute kayo ng body mass index, marunong naman tayong mag-compute niyan. Ang problem, pag pinaklasify sa inyo, check nyo kung anong classification yung hinihingi. WHO 2004 ba o Asia Pacific classification? Kasi magkaiba yun. WHO 2004, common yan ginagamit sa mga hospitals. Okay? Yung Asia Pacific, kadalasan ginagamit sa study purposes. No, ginagamit din siya in some hospitals, lalo na abroad. Pero dito sa atin, it's WHO 2004. So, yun lang yung tip ko sa inyo, no? Basahing maigi yung instructions. No, halimbawa, compute for body mass index and classify according to WHO 2004, ganyan. Check nyo. So, adjustment of body weight for obese, another computation. So, hindi ko na masyadong i-ano yan sa inyo. Skin fold thickness, hindi siya, nung time namin, hindi siya lumabas. Pero, this is important lang na baka lumabas, no? Yung definition, no? Kung sinabing, ano yung ginagamit to estimate subcutaneous fat stores or to estimate total body fat, ang nasa isip niyo na dapat yan, skin fold thickness. Okay? So, yan. Yung skin fold thickness. Other circumference measurements na ginagamit sa weight management, is waist circumference. Ganyan lang, no? Ayan, kaya nilakihan ko yung font eh. Yan lang muna yung titingnan ninyo. Assess abdominal fat content. Okay? Para hindi rin kayo maraming masyadong minememorize. Okay? And if the measurement is greater than 40 or you obtain a measurement at 35 inches more for women, this is an independent risk na for metabolic syndrome. Okay? Ito lumabas sa amin to. Mid-arm or upper arm circumference. Pag ano siya, multiple choice siya. Estimate skeletal mass and fat stores. Then lalabas A, ganyan, B, C. So, ang sagot, mid-upper arm. Okay? Meron din tayong mid-arm muscle or arm muscle circumference. Ito naman provides an index of skeletal muscle mass or somatic protein stores. Ito hindi siya lumabas. Ito yung bagong ginagamit namin as a marker for malnutrition in the elderly. Before, hindi to, hindi pa siya 2018 nung ginamit namin, no? This is calf circumference is measured at point at greatest circumference and less than 30.5 centimeters suggest a protein energy malnutrition among the elderly. So part na rin siya ng comprehensive geriatric assessment namin. Okay? Moving on with biochemical parameters, tapos na tayo sa anthropometric. Biochemical parameters, nandiyan o-order si Doc ng CBC, lipid profile, renal panel, yan. So, para saan ba yan? Okay? So, important that we know yung function ng bawat parameters. And do not use one or sole biochemical parameter to diagnose. No, hindi dapat ganon. Halimbawa, may iba diyan, titingnan yung CREA or yung BUN. Halimbawa, titingnan yung BUN. Uy, ang taas ng BUN mo. Meron kang malamang meron ka ng chronic kidney disease, no? Ganun mo siya binasa. So hindi ganon. Baka naman dehydrated lang yung pasyente. Okay? May problem sa hydration status. No, may edema yung pasyente. Yung mga ganon. So hindi siya dapat binabasa ng siya lang. halimbawa, albumin and pre-albumin. So this is an indicator of the protein status of the patient. But then it should not be used in isolation to assess nutrition status. Okay? Same with yung C-reactive protein naman. C-reactive protein is not common in primary and secondary hospitals. So ang kadalasan meron niyan sa mga big hospitals or tertiary hospitals. C-reactive protein is an inflammatory marker. So lalo na if the patient is admitted in the ICU setting, kinukuha ka agad yan, baseline. Then subsequently, after how many days before the patient is discharged, kukunin uli just to check if na-resolve na yung inflammation. Okay? So ganun lang natin sila iintindihin. And there are parameters na hindi kailangang ulitin on a weekly basis, like serum albumin. Hindi siya lumabas sa amin, sa board exam namin, pero lumabas siya sa ibang year. Tinanong kung ilan ang half-life ng serum albumin, kaya sinama ko siya dito sa slide ko. 21 days ang half-life ng serum albumin. Ang ibig sabihin, halimbawa, yung pasyente na admit ngayon, kinuhanan ng albumin, mababa. Okay? Bago mo makita yung change, yung increase, halimbawa binigyan mo ng high protein diet, maganda ang ang fluid requirement na binigay, ang management sa kanya. 21 days mo pa makikita yung effect nung ginawa mong regimen. No, hindi mo siya pwedeng makita on a weeks or ilang days lang. Unlike pre-albumin na 2 to 3 days lang ang half-life, pwede mo na agad makita. Okay? So, ganun lang ang ibig sabihin yan. Now, under letter C, yung clinical nutrition examination, ang dami nating binabasa, di ba? Pero kailangan nating basahin kasi board exam, hindi natin alam ang lalabas. Buti sana kung halimbawa ang lalabas lang would be hair. Halimbawa, ito ay yung signs, yung pasyente may thinness, lack of luster, ano ang ang kadalasan naman tanong dyan is ano yung possible deficiency Pero katulad nito, ang daming possible deficiency. Okay? Buti sana kung ang tanong lang about gums or nails kasi pwede mong masagot na possible deficiency, vitamin C and iron. Paano kung, hindi, may lumabas magenta tongue. Okay? So yun daw. So sinabi, yung dun sa board exam, merong magenta tongue. Ano daw yung possible deficiency kapag ang pasyente ay may swollen at tongue and magenta in color? So ang possible deficiency na pagpipilian nyo lang, niacin, pyridoxine, riboflavin, vitamin B12, folate, and iron. So yun yung mga kadalasang lumalabas. Okay? Alam ko hair, mouth, tongue, bihira yung gums Pero ito kasi pag tinatanong namin yung mga students namin, yan sa lumabas. Okay, for diet and nutrition history, yan ito matagal to na interview sa mga pasyente. We get to know their economics, ethnicity, yung physical activity nila, attitude toward foods. So, even yung gastrointestinal factors, are they previously diagnosed with GERD or acid reflux disease, yung mga ganyan, or are they encountering a dietary or nutritional problems? Yan, it falls under diet. So, alam nyo na yan, So, this is just to show you yung ating combination of nutrition screening, yung NRS 2002 sa taas, and the SGA or Subjective Global Assessment dun sa baba. So may mga hospitals na ganito ang ginagamit na form, okay, when they do their assessment. Ito, to summarize lang, nutrition screening and assessment help determine the presence and severity of malnutrition among moderate to high-risk patients. Kaya ito yung nakafocus dun sa ating AO. And there are several methods no, in screening and doing the assessing the nutrition status. Nababanggit ko na sa inyo kanina. And factors that affects patient's energy balance. And it is ideal to follow a stepwise approach, yung mga algorithm na pinakita ko sa inyo to determine the nutritional needs of the patient. Okay. So sagutan lang natin to. Pwede ba ako magtawag? Yan, yung nakikita ko sa aking screen, si Miss Cecile Acuesa from AUP. A simple, quick, and general procedure of determining nutritional status used by nurses, medical, or allied health staff. Miss Angel, can you provide us the answer? Hello? May kausap pa ba ako?
Yes, ma'am. Nag-chat po sila, ma'am.
Hi, ma'am.
Sorry, hindi ko alam kung ano kung gising pa kayo. So, si Miss Angel, or si Miss Cecile, si Miss Cecile.
B po, ma'am. B.
Letter B, correct. So, anuhin lang natin yung simple and quick. Ladies and gentlemen, I don't intend na payain kayo, ha? Kaya ko kayo tinatawag kasi mas madali nating matandaan yung mga ganito na exercises kesa mag-memorize. Okay, kesa mag-memorize. Kasi ang dami nyo nang i-memorize. Imagine yung PDRI ng 2015. I-memorize nyo yun. Diba? Dami nyo kailangan i-memorize. Ayoko na nga padagdagan. Kaya we are doing this kind of exercises. Okay. The following is considered in malnutrition syndrome except. So may mga, pag ganito ang question, nasa tingin nyo parang tricky yung dating. Okay? I-isolate niyan. Use isolation. Katulad nung A, B, and C. Okay? Alam, napag-usapan natin kanina, the C-reactive protein is under biochemical parameter and it's not a syndrome. Okay? So, ma-isolate mo na kaagad si letter D. Okay? So, kapag hindi ninyo alam ang sagot, gumamit kayo ng isolation technique. I-isolate nyo yung pinakaiba or yung minsan yung mali yung grammar, no? Yun yung i-isolate nyo, lalo na kung hindi niyo alam yung sagot, no? So this is just a tip lang, no? So this is the end of part 1. Let's move now to the medical nutrition therapy practice guidelines. So magkaiba yung MNT na ituturo sa inyo. Kasi ano naman na yun So this is more of the guidelines that we have now, mga treatment protocol and outcomes. Especially during this pandemic, no, now we are following guidelines set by the American Society and the European Society. Then eventually, nagkaroon ng COVID. So since this is a novel case, novel virus, walang guidelines, no? Walang treatment protocol. So ang hirap, back to zero kami, no? Kumbaga aral uli. Even the positioning, even the provisions of enteral nutrition, the timing and the dosing, biglang inaral uli namin, no? Nakakaiyak kasi hindi lang kayo or yung mga nagbo-board exam na nag-aaral, even us in the hospitals, lagi kami every first Friday may session kami, first Friday of the month may session kami on how we do updates, no, lalo na in clinical nutrition kasi napakabilis lagi ng transition. So I will just show you the latest guidelines that we have in the hospital, no, kasi masyadong madami, so pinili ko na lang yung magagamit natin for this session. We want to present an actual patient case scenario with MNT intervention, and we will integrate theories with practice. Yun yung gagawin natin. Then, in transition, we describe and apply food texture modification for patients with dysphagia, and we will discuss on the benefits of enteral and parenteral nutrition formulations. May mga students din kasi na hindi nakapag-observe masyado ng mga patients na naka-tube feeding or patients na naka-hook sa parenteral nutrition. So, itutur ko kayo doon, no? Para may idea kayo pagdating ng board exam, may idea kayo. Kasi, again, part of the AO natin, lagi kong ine-emphasize yung AO kasi alam ko isasama nila yan eh. Part of the AO dun, ng DOH, yung provisions on enteral and parenteral. Okay? So, moving on with the critical care nutrition management. So, before, in 1940s, no, yung World War II, common na makakakita tayo ng ganitong klaseng malnourished individual. Ngayon, ito nga yung picture 2011. Pero kahapon, meron akong napanood dun sa Jessica Soho na iyak ako eh. Yung taga-Bantayan, Cebu. Na ganito rin. No? Parasitic naman. Okay? Nakakaiyak yung mga ganyang senaryo. Kasi alam mo na, pwedeng mamatay. Napakataas ng risk. Nakita niyo yung kay Dr. Demling, kanina na complications or what will happen if there is unintentional loss of lean body mass. Ito hindi lang to 40%. Okay? Kung 40% lean loss of lean body mass, makikita ninyo na mortality is 100%. Okay? Napakasakit hawakan ng mga ganitong kaso. Similar to what we have na algorithm sa screening and assessment, there is an etiology-based malnutrition definition din naman na ginagamit dun sa Academy of Nutrition and Dietetics. Okay? Again, it's more on the inflammation pa rin, no? Kasama pa rin yung inflammation. Okay? When we do our malnutrition screening and assessment, we focus, lagi tayong nakafocus doon sa, yung pasyente low BMI. Okay? We tend to see the most important key factors. Bakit siya nagkaganon? Or ano yung pwede nating, saan tayo dapat nakafocus na intervention? Is it on the low BMI or we need to do something about the lean body mass or the muscle mass? Okay, so this is an evidence-based ICU feeding algorithm. Parang yung algorithm dun sa part 1 natin. Upon ICU, ganun din, upon admission to ICU. Ang laging tanong dyan, kasi meron tayong surgical ICU, medical ICU, or neurocritical care ICU. Okay? Ang laging tanong dyan is, yun nga, kaya bang kumain ni patient sa bibig? Can we start enteral nutrition within 24 hours? So, yan yung mga tinitingnan nating parameter. Yan yung algorithm na ito. Okay? And if the patient can be fed within 24 hours, ano yung mga acceptable conditions? Okay? And not acceptable conditions. Ano yung mga diagnosis na hindi ka pwedeng mag-start ng enteral? Meron bang bowel obstruction, enteric fistula, or acute pancreatitis? Yan. So may mga ganun tayong scenario. So in evaluation of muscle and fat loss as diagnostic criteria for malnutrition, tandaan lang natin, the diagnosis of malnutrition includes evaluation of muscle and fat. Okay, the role of inflammation not only enhances the catabolism of muscle and fat, but also interferes with anabolism. Right? So ito yung ating causes of muscle atrophy. Or halimbawa, hindi mo yung muscle mass na bumabagsak or na-atrophied, hindi masyadong nagagamit, lalo na yung mga post-stroke patients. There is cachexia or systemic inflammation that happened, especially for cancer patients. Yun nga, babalikan natin yung ating screening and assessment, no? Bakit, no? Yan. Anong nagiging cause? Okay, protein energy malnutrition, yung nakita ninyo kanina, yung nasa starvation phase, and neuromuscular diseases. Now, in critical care setting, di ba, we compute for a target calories and target macronutrients. But in reality, when we compute for that, we only provide around 10 to 20 ml per na ml to run for 24 hours as initial feeding. No, there is such thing as hypocaloric feeding. We give a hypocaloric but high protein nutrition to patients. No, merong mga guidelines that support a hypocaloric feeding intended for these critically ill patients. So kung halimbawa nag-compute ka ng 1,800 calories para dun sa pasyente mo, first ICU day, hindi mo siya dapat bibigyan ng 1,800 calories. Okay? Pwedeng mag-refeed yung pasyente, lalo na kung ang pasyente mo, katulad ng picture na pinakita ko sa inyo kanina, na talagang kakektik ang itsura, tapos bibigyan mo ng 1,800 calories, magkaroon ng refeeding syndrome. Okay? Pwede niyang ikamatay. Magkakaroon ng metabolic derangements, magtataasan o magbabagsakan ng electrolytes hanggang sa mamatay yung pasyente. Okay? So, hindi natin ginagawa yon. We provide a hypocaloric feeding that started 50 to 70% of estimated energy needs. So, kung halimbawa 1,800 calories yung na-compute mo na calories, 50% lang nun or 900 calories lang muna ang ibibigay mo. So, ganun lang ang ibig sabihin niya. So, tatandaan nyo ha, yung we called it permissive underfeeding for critically ill patients. Okay? So, dito sa case na how much and what type of protein should a critically ill patient received, kasi di ba meron tayong book sa, ngayon nag-aaral tayo, we have these mga textbooks, no, when they teach us on how to compute for our protein targets. Ngayon, we rely on journal. We rely on evidence-based multi-center trials. Okay? When we say protein loss or depletion of muscle, this means that it could be associated with impaired function and poor clinical outcomes. Eventually, that will lead to respiratory failure, lack of wound healing, and immune dysfunction. Kaya minsan kumbaga, because of these several guidelines that we presented with our medical practice group, kumbaga na-develop yung policy, our nutrition care policy in our healthcare center, na with or without referral, kumbaga talagang si patient, plus sinupoltahan pa ng ating DOH mandated AO, talagang nababawasan na tong mga incident na to, no, nakukuha na natin, no, nakakaroon na ng intervention. Okay, higher protein delivery is beneficial. Tingnan ninyo hypocaloric feeding pero higher protein yung kailangan. Okay, in protecting muscle mass and associated with improved outcomes. pag sinabing improve outcomes, ito yung decrease in mortality. Okay? Or na-resolve ba yung kanyang feeding problems? Na-resolve ba yung deranged metabolic parameters? Yan. So, ito yon. So, experts concluded that critically ill patients should receive up to 2 to 2.5 gram per kilogram of protein. Pero sa mga textbook, masyadong mataas to. Okay? Pero sa mga journals, yan na yung binibigay nila na recommendations. Okay? Kumbaga, meron pa rin mga hospitals na, lalo na yung mga hindi nagpa-practice ng, hindi updated pagdating sa mga evidence-based trials, na masyadong nasa safe range ba na they under-prescribe and under-delivered targets. No? Yun yung gusto ko lang i-emphasize dito, na we need to continue to study or to read more nutrition journals if you want to be a clinical dietitian. Hindi pwedeng stagnant ka lang or kumbaga para ka pa rin estudyante na nag-aaral ka pa rin. Ganyan. Okay? And this is just to show you the recommendation when it comes to protein goals in enteral nutrition therapy. The recommendations for adult patients, by condition siya, and there is also a recommendation intended for pediatric population. Yan, no? Ako, sa totoo lang, hirap ako sa pag nag-a-assess ng mga pedya, no? Lalo na ngayon that we have 4 COVID admitted pediatric patients. Nakakaiyak kasi hindi, alam mo yun, syempre pag magulang ka na, no, tapos alam mo yung possible na na pwedeng mangyari dun sa bata, ang hirap. Okay, moving on with the optimizing enteral nutrition in the critically ill. Meron tayong, ito yung ginagamit namin for COVID. Okay? So, kapag, the Philippine Society for Parenteral and Enteral Nutrition came up with this guidelines para magamit, no, hindi lang ng hospitals namin, ng hospital dito sa NCR. We also help other hospitals, no. Like yung Philippine Children's, yung mga Mariano Marcos, sobrang punong-puno na rin sila ng COVID. Even last night, Davao Doctors, no, namumblema sila kasi ang hirap i-manage, sa totoo lang. Kumbaga lahat kami, kumbaga at the end of the day, it's the patient is the center of the core. Okay, we need to help each other, no, para lang etong, no, ma-solve tong mga problems natin during this pandemic times. And as you observed, during the acute phase, day 1 to 4, day 1, the permissive underfeeding is 25%. Then go on, as day 2 comes, 50% naman. Yun yung mga targets, no? 50% and 75%. Before, in 2018, the recommendations on day 200% na dapat yung target mo. But this, on this condition, hindi na siya applicable. Okay? So masyadong matubig ang mga baga ng mga pasyente natin. Kaya ang dami naming kailangang interventions na gawin, even yung mga positions, mga pruning positions na nakadapa yung pasyente kapag binibigyan namin ng enteral nutrition, kinokomputan natin ilang ml per hour. Yan, no? And the protein is minimum, the minimum protein that we provide is 1.3, considering that this patient is is on CRRT or continuous renal replacement kung ito ay merong renal problem. And post-ICU target, upon ICU discharge, we can increase to 1.5 to 2. And post-hospital discharge or target 3, we can increase the protein to 2 to 2.5. So, ganun pa rin yung targets natin. Pataas ng pataas. Okay? Habang tumatagal. So this is the summary of recommendations based on ESPEN and ASPEN guidelines and clinical practice guidelines of 2015. And again, the recommendations is avoid early full enteral nutrition or parenteral nutrition. So yun nga, no, dapat mag-hypocaloric feeding. So that is permissive underfeeding. And the target, ayan, may mga set target rate na dapat i-achieve on day 5. Okay. So next question. Hypocaloric feeding may be started with 50 to 70% of estimated energy needs or less than 14 calories per kilogram actual body weight. True or false?
True.
True. So, tingnan niyo yung question. Again, ang technique dyan, very specific. No? Pag very specific yung sagot, yung tanong, at hindi mo alam, nagkataon na hindi mo alam yung question. Kung yung sagot dun sa question, at very specific yung tanong, most likely ang sagot dyan, true. Okay? Ganun yun na lang siya tingnan. Pero as much as possible, mag-aral kayo para hindi kayo nang huhula. Okay? Pero ganun yan, no? Check kung specific masyado yung tanong, most likely true yung sagot. Again, number 2, experts have concluded that critically ill patients should receive up to blank of protein. Ito, in-emphasize ko to kanina. Letter?
B.
B, correct. 2 to 2.5. That's the target, no? Initially, hindi siya. No? Makikita ninyo yung transition. Okay? Moving on with parenteral na tayo. No, hindi matapos-tapos na algorithm. Pero ang gist lang naman nito, if the gut is not functioning or the gastrointestinal tract is not functioning or pag totally not functioning, it's total parenteral nutrition. If the gut is functioning a little or partly, that's partial parenteral nutrition until the gastrointestinal function returns. Paano mo ba masasabi na partial? So kami, paano ba namin na-determine na partial lang yung kaso ng pasyente? Okay? So pag halimbawa nagbigay kami ng feeding initially na sabihin namin 20 ml to run 20 ml for 24 hours. Nagbigay kami ng ganong recommendation. Nag-run siya, no? Walang complications, walang bloatedness, maganda ang fluid INO. Halimbawa, in-increasean namin. On day 2, nag-increase kami. From 20 cc, ginawa naming 30. Ginawa naming 30. Pagdating ng 30, biglang sumakit ang tiyan. May biglang nag-bloat. Andiyan may biglang nagtae. O kaya biglang nagkaroon ng gastric residuals na mas madami pa dun sa in-enter namin na volume. Then that scenario alone would tell us na gumagana yung gastrointestinal tract pero hindi fully. So partial lang. So ang gagawin namin, we stick with the 20 ml, then we give the remaining calories from parenteral nutrition. So ito yun. So there is an access or route of feeding. By definition uli, no? Kailangan ibigay natin yung definition kasi ito yung madalas ibigay sa sa board exam, yung definition. Kaya nakakainis kasi ang dami mong kailangang i-memorize or basahin. Pero yun nga, mas maganda kung intindihin na lang para hindi na kayo mag-memorize. Parenteral nutrition is a provision of intravenous nutrients. Period. Yun na muna yung tandaan mo. Tandaan mo, if the gut is not functioning. Okay, so madaling tandaan, no? Parenteral nutrition, IV nutrition, gut is not functioning. Ano ang route of feeding niya? Dalawa lang, central access and peripheral access. Yung central venous access mo, yung malapit sa leeg. Yan, no? Kumbaga, kailangan yan sa catheterization laboratory ginagawa, ini-insert. No, hindi siya yung basta tube lang, no? Kailangan ng cardiac expert, no, to insert the catheter. Then yung peripheral access naman, yan yung nasa braso for short-term parenteral access. Okay? Again, parenteral nutrition refers to combination of nutrients. Ibig sabihin, yung carbohydrates ng sa parenteral nutrition, dextrose na. Yung proteins, pagdating ng PN or parenteral nutrition, ay amino acids na. Tapos yung fat ay lipid emulsion na. So, imimix yan. Imimix yan. Napakamahal niyan, no? Nasa 12,000 isang bag. So, just imagine, 12,000 or more. Depende sa brand. Ihuhook lang sa pasyente 24, good for 24 hours. Okay? And we also tailored our computation based doon sa need ng patient. Yung ganyang kalaking bag, hindi kakayanin ng mga neonates yan. May mga neonates tayo na nasa critical care, critical care units, na maliliit lang yung volume na kailangan nila for parenteral nutrition. So just imagine kung yung maliliit na kailangan lang nila, babayaran ng patient yun buong bote. Diba? Halimbawa, ang kailangan mo lang is 10 ml, pero yung bote no nasa 500 ml. Babayaran ng pasyente yung buong 500. Kumbaga napakamahal ng parenteral nutrition. Okay, this is indicated for patients who cannot, should not, and will not eat adequately using the gut. Yun lang yun, no? Para hindi kayo maraming minememorize. Again, the indication for parenteral nutrition, sino-sinong candidate dyan? Those who cannot, should not, will not adequately maintain nutrient stores using yung ating gastrointestinal tract. Okay? Para wala kayong masyadong minememorize. Now, initiation, kailan siya binibigay? If early enteral nutrition is not possible within the first day up to 7 days, yan, no, bigay na kailangan ng i-provide. Okay? Or if the patient is with evidence, katulad nung nakita ninyong patient kanina na skin and bones, yan, ano yun pag EN is not possible, lalo na dun sa case nung kay Jessica Soho, dapat yun parenteral, start no slowly, okay? Immediately after admission and resuscitation. Okay? Ito yung sinasabi ko sa inyo kanina, the macronutrients is different kapag enteral nutrition and versus parenteral nutrition. So ito, absorb na lang ng absorb. Hindi na to dumadaan sa normal digestive tract, no? Kumbaga, IV na siya. Kaya siya may kamahalan compared sa enteral nutrition. And we do different side drip. No, on top of the macronutrients, may mga side drip na electrolytes or vitamins or trace elements na binibigay together with one bag of PN. So ito yung itsura niyan pag nagpapakain. We have a continuous administration cyclical delivery, and gradual transition using, of course, an infusion pump. Now, the most common metabolic complication is dehydration. Kaya, important na nagbabasa tayo ng fluid input and output record ng mga nurses. Okay? Dito pa lang sa decrease urine output or rapid, ano na tayo dyan worried na tayo dyan, no? Okay. Important yan, input and output. Same, no? Same algorithm. If the gut is functioning, then enteral nutrition. Pag sinabing enteral nutrition, don't common yung mga hospitals na sa kanila blended rice or home brew. Ito yung mga nagko-compute tayo ng gulay, prutas, karne, milk, tapos bine-blender natin. Ngayon, sa mga tertiary hospitals, yung malalaking tertiary hospitals, kahit yung iba malalaking government tertiary hospitals, meron na silang formula. Formula na yung ginagamit. Now, you need to determine lang kung ano yung appropriate formula doon sa pasyente. Do you need to use the standard or polymeric formula? No, by definition, these are intact nutrients. No, para lang din siyang blenderized home brew na ginawa mong powder. Yun lang yun. No, elemental and semi-elemental formula. Ito yung mga formula na partially or completely hydrolyzed na. Ibig sabihin, halimbawa, yung amino acid, yung protein nun, pagdating dito sa elemental, amino acid na yung ginagamit. No, hindi na siya yung, kumbaga, completely hydrolyzed na siya na amino acid. Kaya i-absorb na lang ng pasyente. Hindi na siya dadaan ng normal digestion. Kaya mas mahal din siya. Okay? Yung disease-specific naman, yan yung pang-diabetic, pang may kidney disease. Yan yung mga disease-specific formulas natin. And modular, for halimbawa, the doctors or the dietitians would like to correct the protein condition of the patient or the protein status of the patient, then she may add modular protein on top of the standard polymeric or the disease-specific formula. So ito yung mga sample ng ating standard polymeric formula. Kung familiar kayo sa Ensure, familiar kayo sa Boost, yan, no? Yung elemental naman, dalawa lang elemental na available sa drugstores, yung Peptamen saka Alitrac. Yung Vital HP, sa mga major tertiary hospitals lang meron nun. Diabetes, ito yung mga disease-specific formula for diabetes and disease-specific formula for renal. So, pwede kayong halimbawa, pumunta kayo ng Mercury, no? Part ng ano ninyo, part ng tour ninyo, basahin ninyo yung mga labels, no? Kumbaga, para maaral nyo rin siya. No? Silipin nyo lang ano yung content niya, ano yung source of protein na ginamit sa kanya, bakit siya can easily absorb compared to other sources of protein, yan. Even yung cancer-specific formula, ProSure and Supportan, and modular and additives. Yung additives, gumagamit kami ng mga probiotics and fish oils. No, meron tayong mga other guidelines. Halimbawa, sa cancer guidelines natin, included na yung therapy nakasama ang fish oils. So, we dose din ang fish oils and probiotics, yung mga, if the patient is on multiple antibiotics and we need to have a good gut balance na intestinal flora, then we use different probiotics. We dose that. And we teach the nurses to do that, by flushing. Hindi siya kasama ng formula. Okay? When we do feeding tube selection, kailangan ma-establish kung short-term or long-term ba siya na gagamitin. If less than 6 to 8 weeks, then the patient can be hooked on nasogastric tube or nasojejunal tube. But kung long-term naman, on the other hand, the patient can use the percutaneous endoscopic gastrostomy tube or the PEJ or percutaneous endoscopic jejunostomy tube. No, direct na siya. Okay? Kadalasan ina-access yung PEJ kung halimbawa mayroong stomach cancer tapos tinanggal yung buong stomach. Tapos ang next route of feeding would be the small intestine. Doon na siya direct na ina-access. So long term 'yon. Kaya para lang siyang button, no? Doon ka magpapakain ng tube feeding through that button. So at least hindi katulad nung nasa ilong. Nakita-kita, no? Pag naka-PEG or PEJ, no, medyo discreet pa. Pero sila hindi na sila pwedeng kumain sa bibig. Okay? So this is just a good to know slide na merong mga sizes, no? Ang different tube type, like a nasogastric tube, ang size niyan is between 8 to 12 French or 36 inches ang length and so on. Okay? So ito ang itsura ng ating nasogastric tube, PEG tube, and nasoenterocoral jejunal tube. Again, not all hospitals can insert a nasojejunal tube. Okay. And even in pediatric, we avoid provision of bolus using yung asepto syringe, yung malaking yan, no? Yung parang pang ng ham, yung ganyang kalalaki, because we want to avoid aspiration or cases of aspiration. Maraming side effects yung ganyan. What we do, especially for babies or yung mga adult na walang pambili nung pang-intermittent tube, we use a Tumi syringe, yung mas maliit ang And for the period of 5 to 10 minutes every few hours ang provision. We also have a gravity set feeding. This is ito lumabas to. Natatandaan ko to na sinabi nung staff ko. Lumabas sa board nila yung definition ng gravity feeding. So this is an administration technique, no? It could be done continuously, no? Delivered using a special delivery system or yung tinatawag naming enteral pump. Yan. Continuous pump controlled. Yan, meron sa amin all patients on ICU should be hooked on enteral or infusion pump. Even in Cebu, meron din silang ganyan. Sa Chongwa, meron din yan. Sa Cebu, sa Davao Doctors, yung mga malalaking hospitals natin around the Philippines, they have that continuous pump controlled feeding. Ito yung sinasabi ko sa inyo kanina na one of the common tube feeding problem is gastric residuals. It could be colored black, pwedeng maroon, pwedeng yellow. Okay. Now, before, the practice is, kapag nagkaroon ng gastric residuals, hinohold ng doktor yung feeding for 24 hours. Ngayon, the new guidelines would say na ibalik mo lang, no, yung gastric residuals, ibalik mo lang, then monitor, then you start the feeding again. Okay? Kung yan naka-intermittent, then balik mo lang yung gawin mo continuous feeding lang. Okay? Or kung nasa bahay naman, you may use a smaller syringes. Pero hindi ibig sabihin na may gastric residual volume, i-stop mo na yung pagpapakain sa pasyente. It's not true. In France nga and in Germany, kahit 500 ml yung nakukuha nilang gastric residuals, hindi nila hinohold yung feeding. Okay? So, depende talaga sa guidelines na ginagamit or protocols na ginagamit dun sa medical center nyo. Another common tube feeding problem is constipation. So sa atin parang andali lang, di ba, na constipated, tubig lang yan. Diba? Probable cause lang, not enough water. Pero in reality, you have to check, is the patient ba on a formula na low fiber or there is a medication, no, na merong side effect kaya nagkakaroon ng constipation, no? Kasi kadalasan kapag may tube feeding problem, ang laging culprit nila tube feeding, no? Kaya as a dietitian, you need to know, is it really the food or the feeds, or is it something to do physiologically, or is it because of the medications that the patient is taking? Okay, lalo na kung diarrhea. Kahit naman tayo, kahit hindi tube feeding, no? Kapag nagtae, ang lagi mong iisipin, ano yung huli mong kinain, 'di ba? Ganon, which is hindi siya dapat ganon. Okay? No, you have to check with the probable root cause. In enteral nutrition, if the formula is given too fast, yan, it may cause GI upset. Or if there is too much fiber naman then, no, or there is bacteria in the feeding. And same with medication. Kapag ang pasyente, napapansin namin, if the patient is on multiple antibiotics, kaya nagbibigay kami ng probiotics para hindi siya magkaroon ng diarrhea, no, para mabalance yung intestinal flora. Or if the patient is on sorbitol or mannitol containing medications, yan, nagtatai talaga yung pasyente. Okay? So yun yung mga pwedeng culprit. Hindi laging yung tube feeding. Okay? And other etiologies of diarrhea na pwedeng because of malabsorption. Naman, yan yung mga partial na pwede naming i-consider na combination of both enteral and parenteral nutrition. Again, diarrhea is not often caused by enteral nutrition. So you have to investigate the cause before you withhold the nutrition support. So this is just a sample of monitoring forms that we use. Yan, para ito nasa ibabaw to ng chart para nakikita kaagad nung doctor kung ano yung target calories, saka kung ano lang yung calorie intake ng pasyente. The target dito, kumbaga nga sa passing score ay 75%. Okay? Kung 75% pataas hanggang 100%, so the patient is eating or getting adequate calories and protein. But if not, kung halimbawa less than 72, then that means inadequately fed yung pasyente. Okay? So another algorithm. So let's move now to transition from enteral, ibig sabihin from tube feeding, kakain na siya sa bibig. Okay? Common nutritional problem natin is dysphagia or impaired swallowing, which is a risk for malnutrition and aspiration pneumonia. So kadalasan ito makikita natin doon sa mga geriatric population or those post-stroke patients. Kasi maluwag yung sphincter nila, no, doon sa panglunok. So dahil dalawa yung daanan, 'di ba, yung daanan na pag kumain ka sa bibig. Yung isa papuntang esophagus, yung isa papunta sa lungs. Ngayon, kapag katulad nating normal lang muscle ng sphincter natin, alam natin na yung food na kakainin natin sa bibig, papunta yan sa esophagus. Sa mga patients na post-stroke, nagkakaroon sila ng dysphagia or yung hindi nila nakokontrol yung pagpasok ng solid food sa esophagus. Minsan napupunta siya doon sa daan papunta sa lungs. So nagkakaroon ng aspiration. So imagine niyo kung nagkaroon ng liquid or tubig sa baga, no, napakalaking chance na pwede niyang ikamatay kapag hindi naagapan, or yung procedure na lang para matanggal yon napakamahal, para ma-drain yung mga fluids na napakamahal. Okay? I-insertan pa ng tubo. Okay? Now there is what we call functional endoscopic evaluation of swallowing. Sa ibang hospitals, meron silang bedside swallowing test na ginagawa ng nurse. Ngayon, meron ding mga ganito sa malalaking hospital. So this test is to check the ability of the patient to eat orally. Halimbawa, katulad nga nung sabi ko sa inyo, yung patient naka-tube feeding. Sabi niya, Miss Butch, gusto ko nang kumain sa bibig. Pwede na ba akong kumain sa bibig? Gusto ko na kasing tanggalin tong nasogastric tube ko. So of course, hindi ko yun papatanggal. No? Magre-request ako na mag-undergo siya ng fees. Okay, no. So magre-request ako sa chart na suggest kunyari, patient would like to remove NGT, suggest fees, care of ENT doctor, halimbawa, ang gusto ko doktor na ganito pangalan. Okay? So i-refer ko siya sa doktor na magkakandak nung fees. So during the test, bibigyan siya ng dietary department ng 5 sample foods na lahat kulay green. Ice chips niya green, crackers niya green, tin liquids niya green, lahat green. Tapos, lalagyan siya ng scope, no? Video guided scope. Meron siyang, yung mahabang tubo na yan, ipapasok sa ilong niya. Of course, may anesthesia na i-spray dun sa ilong, no? Para maging comfortable yung pasyente. So, sa totoong buhay, hindi talaga nakangiti yung pasyente habang kinakandak yung fees. No, it's very uncomfortable. Ikaw napasukan ng tubo sa ilong. Then from that, yung dulo niyan may video. Makikita sa screen kung yung food na pinakain ng doktor sa kanong nurse, kasi meron siyang nurse na katabi na magpapakain habang hawak niya yung tube, ay yung video guided scope. Kung yung bang pureed food ay pupunta sa lungs or pupunta sa esophagus. So makikita yung transit, yung dadaanan nung pagkain. Okay? So, ang pinakamahirap lunukin or pinakamasakit lunukin ay tin liquid. No, yun yung pinakamasakit sa kanila. Kaya we have this tawag dito, yung mga ginagamit namin na para siyang cornstarch, pero hindi naman siya cornstarch, to facilitate good swallowing. We called it thickener. Okay, na medyo may kamahalan, but it facilitates good swallowing. So, ito yung itsura niya. Okay, these are the different thickeners in the market. Na minomold yung foods, tapos nilalagyan ng thickener. So, parang halimbawa, gustong kumain ng pasyente ng Oreo. Di ba matigas yung Oreo? So, magtitimpla lang kami ng thick and easy sa pan. Konti lang yan. Tapos, ibababad lang namin dun yung mga Oreo. For 20 to 25 minutes, lalagay sa ref. Tapos, after nun, wala na yung liquid. No? Na-absorb na ng mga Oreo cookies yun. Tapos, kapag kinain na yun ng pasyente, parang melts in the mouth na, no? Para lang siyang, lunok na lang siya ng lunok, no? Hindi na mahihirapan. So, yun yung purpose niyan. So, what happened pala dun sa fees? No? Doon malalaman kung yung pasyente, kung tolerate na niya kumain sa bibig. Kung pwede nang tanggalin yung NGT niya. Okay? Yun ang purpose nun. Now, there are patients na hindi pa kayang i-tolerate yung mga full diet, kaya magkakaroon ng transition from dysphagia level 1 diet na pureed to minced, to ground, tapos to chop. So, ganyan ang sizes niya. Okay? So, mga high-risk foods na hindi natin sinasama kahit sa mga tube feeding natin, ito, na to ha, sa bibig na ito. Pero hindi kami nagsasama ng pinya or ng mga fiber, yung mga masyadong ma-fiber or yung mga vegetables, or hindi namin sinasama yung skin ng mga vegetables and fruits. Yan. Saka mais, yung mga nuts, no, assorted nuts, hindi pa rin natin siya binibigay for trial feeding. Okay? So let's have an actual hospital case. So gusto